It's been so great to see all of the interactions and the conversations that we've had today. And so we're going to continue our theme here about changes after pituitary surgery, or maybe even before you've had pituitary surgery, and the impact that's had on your life, whether that's surgery related, hormone related, or just quality of life related. So again, we'll just take questions as they come.
So what innovations are you excited about in intranasal surgeries?
Well, I am excited about what we're doing daily. Excited because, as I told you before, we are pushing the envelope and developing techniques that are improving the outcomes clearly. I'm excited about being able to further demonstrate that the techniques are really useful. As we mentioned, there are still endocrinologists, not Julia and many others, that we work closely together because they see the results daily, but others that are out there that don't have the same connection with experienced surgical team, let them know that they start knowing that these surgical techniques are more and more effective. And I am excited to see that this happens not just at Stanford, but happens at many other places. People we've trained, and they are doing this in different institutions, and I'm very excited about that. Well, we'll see what the future brings. There are many advances that are upcoming. Among them, I think the most exciting would be robotic surgery, in the sense that we'll have probably in the next 10 to 15 years, I would think. You've heard of the Da Vinci robot. Da Vinci robot is something that is made for, urologic or abdominal surgery in general. It is a fantastic machine, but it's very big and bulky. It is not good for brain surgery for use of the nasal cavity. It has to be much more. It has to be smaller. It has to be more precise. There are many engineering challenges there, but they will solve it, I'm sure. And the ability for me to have a tool, which would be a robot, I still will be on the console. We'll still be on the console manipulating the robot and directing it. But instead of being our hands directly, we'll have even more steady hands, and they will be less fatigued. And I think you can do things that there are some things we cannot do working through the nose, like suturing, because you don't have enough space to rotate your hand, that a robot can do. So there will be things we can do better with a robot. So that would be exciting to see. Thanks for the question.
I also just want to comment earlier when you mentioned how many endocrinologists don't necessarily see repeat surgery as another choice. Last year we have our endocrine fellows do these board review prep questions every year. And one of the questions was, what would be the next step in someone who has residual disease in the cavernous sinus? All of our fellows here said repeat surgery. But actually that was not the board review question. But I think that just kind of speaks to how, innovative we are here at Stanford. And we're very fortunate to have our fellows train and the next generation of leaders be exposed to these techniques. So
yeah, I would say also that when I first started introducing these techniques to our neurosurgical community, skull-based community, the most students some of them were enthusiastic, but some others were rejecting the idea. And I was criticized. They were criticizing me for, being too aggressive. Why you do this too? They were saying, only if a patient has Cushing's disease, because drugs are not very effective for Cushing's, although they are better now. With that argument, maybe there is no indication to do this, but they were saying you shouldn't do it it's not wrong. It's wrong to do it in some other patients because medical treatment is effective, or you have radiation. But, gradually with the results, it's shifting clearly. And the same things that were criticizing a few years ago, they are now adopting these techniques. And that is very good to see.
I heard about the approach that you open from below the eyebrow from here in South Korea. What do you think about that?
Yes, actually, I know the surgeon, Dr. Kong, he's a colleague of mine. in Korea. And we've done some of those operations. Yeah, you can do the same way we work with our ENT colleagues, we can work with our oculoplastic surgery colleagues, and they do incisions around either on the brow or on the eyelid crease. And you can access, it's not good for the pituitary, but it's good for, let's say, to the sides of the pituitary. You can go to the cavernous sinus that way. You can go to what is called the middle fossa, what is behind the eye. Let's say, imagine the pituitary is behind the nose, not good for that. But what is behind the eye, in the brain side, you can go through these areas, around the eye. The benefit is that it's less invasive for patients. At the same time, you always need to be careful when you adapt that because the space is more limited. What you can do is not as advanced or accurate as you can do with a standard opening through the side of, the side of the head. Yeah, I see you are up to date, Doris, on surgical techniques. Yes, it's true. Yeah. Erin?
This particular circumstance is a postmenopausal female with acromegaly who's on estrogen and progesterone replacement to be treated with testosterone due to low testosterone levels. And the question would it be safe to do this? And what is the safe treatment target for testosterone?
Yeah, that's a great question. So, after menopause, there can be many changes in life. That's, why it's sometimes called change of life. And hormones with estrogen and progesterone replacement can help with things like sleep and sometimes mood and not just kind of temperature fluctuations, which you might hear about commonly. And so it's an individual conversation. I think the conversation about estrogen and menopausal hormone therapy has really changed in the last 20 years. I think in early 2000s, there were a lot of studies that showed some of the risks of being on certain types of oral estrogens and certain types of progestins and risks of breast cancer and stroke and blood clots. And so many primary care prescribers and endocrinologists started to discontinue those prescriptions, but perhaps maybe too much, and maybe the pendulum kind of swung in the other way. And so I think now, maybe 20 years later, we're seeing which patient that, how hormone therapy can still be important for, can still benefit, even in their early 50s or mid 50s. It's always a conversation of how long to maybe continue estrogen and progesterone for, because the risks of breast cancer are real and they do go up with age. For patients with acromegaly, and actually, for anybody who may be on growth hormone, estrogen can have, oral estrogen in particular can influence IGF-1 levels. And so that's an important interplay. So if someone's on transdermal estrogen versus oral estrogen, once growth hormone replacement doses can change, it might even affect their IGF-1 levels as well. And then the question about testosterone for low libido in women. So that is one area where sometimes actually compounded testosterone we do sometimes use. And I don't think you'll see many endocrinologists talk about testosterone in women. But part of my other hat actually in endocrinology is providing gender affirming care. And so I have a little bit of experience with that. And it can be very helpful in older women who've really experienced a sudden loss of libido after a certain age. But it has to just be monitored carefully. We certainly wouldn't want to do too much. And you would just have to follow clinically for certain symptoms and side effects.
You had a question next, and then I'll come to you.
So I have a question. Actually, with steroids. So I met one lady probably 3 years ago. She was engineer, I don't know where, Apple or somewhere. And she actually rigged up, she used insulin pump and she changed it to steroid pump. And she had a monitor of cortisone in the blood. and she basically run like on steroids. So compared to me, I'm like really sluggish. I already told 5 hours I'm awake. Then I need to recharge like for 2 hours. And then I have 5 hours again. And it goes 24/7 basically. So, and I don't know if just me or if there's some other people have the same thing, that I'm really tired and cannot figure out what do I need to do. And also side effects. I'm pretty diabetic. I gained 50 pounds and osteoporosis and high blood pressure. So what's next?
Yes, the question about using hydrocortisone as a continuous infusion came up in the last session too. And I do think that there could be a role for that in certain patients. We just don't have, I think, much experience in terms of guidance about the dosing. But I do have, or I did have one patient who was on that on a hydrocortisone pump, and it worked very well for her. I think as we know more about how we can potentially use hydrocortisone in an infusion manner and maybe bolus during certain times, kind of similarly to how one would do with the insulin, I think that would be really, really interesting. I think that could be one of the next phases potentially of adrenal insufficiency management. But so far, it's just, we don't have a lot of experience yet. You would have to be certainly very careful not to over replace because a lot of some of the conditions that you actually just mentioned can come along with over replacement of steroids. So with prediabetes or osteoporosis, higher blood pressure. So there can be a fine line there.
I'm pre-surgery and hoping to get surgery. And in the meantime, my endocrinologist has upped my doses of cabergoline for my prolactinoma to a pretty high level. And he wants me to get surgery. And the surgeon says, no, not yet. My question is, so I take cabergoline and I want to ask if you have any experience or opinions on switching to the older drug or maybe going back and forth, if that might help, or taking both at the same time.
So for people who are not responding well to cabergoline, it is possible to switch to bromocriptine, which is the other dopamine agonist. It generally doesn't work as well though. I mean, so I'm not always optimistic that the prolactin would necessarily respond or that the tumor size would necessarily shrink on bromocriptine versus cabergoline. I've not had anybody take both at the same time. I don't think that would really be any more bang for your buck. Yeah. Yeah.
So just as a thought for those of us who had post-surgery, obviously as an endocrinologist, Dr. Chang, you want to prescribe and you're looking at the hormonal balance and you're trying to work that out. It's kind of a trial and error, I suppose, right? For those of us who are able, if you have a really good exercise regimen, right, that causes some kind of biochemical response in your body. For those of us who are dedicated to do that, who can do that, what kind of mitigation does that offer someone, just generally among your patient population that you might have been able to observe?
Yeah, I mean, I think the benefits of regular physical activity, exercise, diet, sleep are so important. And I'd love to hear more from you, Catherine, about that. Usually when they're talking to me about these issues, they've usually kind of tried to maximize all of that already. And so, I'm kind of already on that other end of the conversation. But I always use, or consider good sleep hygiene, regular activity, good eating habits as really the first part of any healthy lifestyle. So, but yeah, maybe Catherine, if you wanted to speak more about that.
Yeah.
improves outcomes in your.
Oh, absolutely. And like just in terms of mood and day-to-day outlook. Yeah.
Quality of life, how it's just what I work with, something consistent with every painful circles, so that's all they can do. The better they can do. I also want to tie in, the last gentleman spoke about sleep, being so fatigued. Do you think there's value to getting your circadian rhythm back? And you don't want to be sleeping all day. You want to be really sleeping at night. Unless that's part of a lifestyle. Or to really look at how you're focusing sleep function. For mood and quality.
Jumping off from that point a little bit, I know that Stanford has a strong CBTI program, CBT for insomnia, and I think that sounds like a potentially appropriate referral for people when they're starting to deal with some of the after effects. But I had been wondering before that about whether there is any coordination with mental health services or if there's someone in-house, if that's typical at all in centers of excellence, where you see a lot of these cases where there's some kind of synergy where you're able to refer people to mental health professionals who have had an opportunity to learn about how to handle clients who have these experiences, given that they're pretty rare disorders. If that's part of the standard of care of connecting to mental health and social support services.
I think it should be the standard of care. I think just as living with any chronic condition that can, whether that's pituitary or not pituitary, how that affects one day to day, and not even just having to take multiple medications and that impact. But I do think that should be the standard of care, whether it's, at a pituitary center of excellence or, even out in the community. Yeah. And I know there are many programs that incorporate that as part of their programs.
Maybe something to that. I didn't mention it during the presentation. That I'll hear from prospective patients out in Los Angeles. I want to find somebody like you who knows all about Cushings. You don't need that in the counselor. You need a counselor who's going to be able to listen to you, validate, use some good resources. Please know that I would be with finding a counselor that is fit. Never heard back if the counselor needs them. Feel free to give them my name and number, and I will provide a consultation to your counselor to educate them on what you need. Please, I would be more than happy to.
Hi, I just have a question about post-surgery nasal stuff, and unfortunately, I guess the ear, nose, and throat guy is gone. But maybe you guys
I can
have
fill it for
some.
him.
Yeah, you have some information. But I've had 3 pituitary tumors removed by Dr. Kunwar, and I have post-nasal drip all the time. I'm constantly clearing my throat, and also after the 3rd surgery, I think I was just blowing my nose maybe a little too hard, and I feel like underneath or above my soft palate on the roof of my mouth, something kind of flaps up and it almost kind of blocks my nose a little bit from being able to breathe through it temporarily. So these post-surgical nasal surgery things, I don't know if you have any ideas or opinions on that or.
I do. First, so there are historically transphenyl surgery was done only by neurosurgeons. Like the neurosurgeon would just we would do the approach, and when I was in residency, that's what I learned, how to do the approach to the nose ourselves, and it was quite simple. You just go into the septum and split the skin and put a speculum and open it up, and then you have the corridor and the access there. The problem with that is that we neurosurgeons do not, my personal opinion is that I believe in super specialization or supra specialization, and then I love working with my ENT colleagues because they do know better about the nasal cavity than I do. So I rely on them on doing the approach, which is the more contemporary way of doing things. You have a team, ENT does the approach, the neurosurgeon works together to remove the tumor and then close and reconstruct. So my advice to you would be to see an ENT surgeon. They had them at UCSF, of course, that you can see that they're expert in sinonasal issues, or you can come to see one of our ENTs at Stanford. They're phenomenal. So they can scope you. Yes, in their office, they put an endoscope to the nose, and many of you have experienced that. It's not fun, it's not pleasant, but when it's for a routine check, it's much easier than when it's post-op. When it's post-op is when it's really rough. But they can see what is wrong, and sometimes you have a large septal deviation, septal perforation. That is what makes things difficult. It's impossible to tell without looking at your nasal cavity, but it's easy for them to look at your nasal cavity with direct inspection, and that's what I would recommend. Thanks. Yep. Do you know the age of the patient? Yeah, it's very difficult to answer with that limited information. As a surgeon, you always want to look at a number of things. Among them, of course, the MRI. Also, you have in my patients looking at the MRI is a key part of things for me to understand what a tumor of 3 to 4 centimeters is quite large. And you would think that a tumor of that size will require treatment. Now, there are exceptions. Let's say you are an elderly patient and you have no symptoms. You can watch it. You are doing okay. But you're younger, you're gonna need treatment. So you have to get a comprehensive evaluation. You need to get visual checks by the neuro-ophthalmologist, visual fields, see whether it's really impacting your vision or not. Because sometimes you say, "Oh, I'm fine," but then you do an examination, you see you're losing your peripheral vision, but you are not noticing it much. Number 2, you want to check your hormones. You say, okay, my hormones are fine, but then you check your hormones. Maybe you find out that your growth hormone is low, your testosterone in your male is going low, and explain some of your fatigue and etc. That being said, and third, of course, consult with an expert neurosurgeon on craniopharyngioma surgery, which there are not many because that's a very difficult operation. It requires a lot of expertise. But there are very good surgeons out there. You just need to find them. Overall, it is always a good balance on craniopharyngioma surgery is always a difficult operation, and it always carries risk. And you always need to wonder, is the risk of intervening lower or higher than the risk of not intervening? But generally speaking, not very old patient with reasonable health with a 3 or 4 centimeter craniopharyngioma will typically recommend surgery just because of the size of the tumor. It's going to cost double sooner or later.
I just had a question too about the way that Dr. Kunwar does his operations as opposed to yours. Is it different? I mean, I had the in the nasal cavity having a sinus invasion of the tumor, and it just from your presentation earlier, there's this connective tissue that you're using, and I mean, I don't really know what exactly he's doing, but I'm just wondering if what you're doing is different because you've created these tools and whatnot, and so. I don't. Maybe you don't even know. I don't know.
I do know. Although I don't like to talk about other things specifically with first and last name, but there are as we mentioned before, there is let's say an old school, which is a traditional way of doing pituitary surgery, which is dying down, which is with a microscope, and that's a basic difference than with a microscope. You can do very good surgery with a microscope, and there are phenomenally very experienced surgeons doing microscopic transsphenoidal surgery. But it is an art that is actually dying because the endoscopic approach is superior. You see better, you can do better. So that is the fundamental difference. The tool that you use for visualization. Now, the fact that you use an endoscope doesn't mean it's gonna be great. You're gonna do a great operation. You need to know how to, do things that you're seeing them. Doesn't mean you can do them. You need to be able to see them and then manipulate structures in a way that is safe, that is effective. So it's not just about the endoscope, but a well-done endoscopic surgery is superior than a well-done microscopic surgery because you can see better, you can do more.
First of all, thank you so much for all of this today. It's been amazing. And my question is for both you, Dr. Fernandez-Miranda, and you, Dr. Chang. The difference between a Rathke's cleft cyst and an adenoma. I know from my own experience kind of what happened, but could you just talk about the different pathways of surgery and also follow-up treatment?
So yeah, Rathke's cleft cysts they are not tumors, they are cysts. You remember the pituitary gland has two lobes, anterior and posterior. The anterior lobe is the bigger one, produce most hormones, and it comes from the oropharynx in development, while the posterior lobe of the pituitary comes from the brain. And they both fuse in development. And in between the anterior and posterior lobes, there is a cleft. Just because they come from different, is the junction between the both of them. That cleft, in some patients, can develop a cyst. And that's what we call a Rathke's cleft cyst. Now, many Rathke's cleft cysts are relatively straightforward, small or medium size. Most of them we don't operate, we just watch them. Only patients that develop really bad headaches or some abnormal pituitary function, we would recommend surgery. It's different than a tumor. That we more often would recommend surgery because tumors grow. And we know that if you are young, the tumor will grow and in the future will cause trouble. But if it's a cyst only, we often recommend observation unless there are significant symptoms. Now, within the Rathke's cleft cyst, there is a wider spectrum too. There are some cysts that are more complex. In fact, we speculate that Rathke's cleft cyst and cranopharyngiomas are part of the same family. But cranopharyngioma is one extreme over there, and Rathke's cleft cyst is another extreme right here. And in between, you can have different variants. So there are Rathke's cleft cysts that are almost as complex as cranopharyngiomas in the sense of they're involved in the pituitary tissue, they're involved in the pituitary gland, their size, and therefore the operation has a higher risk of pituitary dysfunction. Probably you gather from some of the opinions here, the risk of pituitary dysfunction after a pituitary operation for a pituitary tumor is actually very low. It's only about 5% that patients will get new pituitary dysfunction. For Rathke's cleft cyst that are simple, also is quite low. But for cranopharyngiomas, it's very high. It can be as high as 80 or 90% of patients with cranopharyngiomas will develop pituitary insufficiency. And some complex Rathke's cleft cysts can be almost in the category of those cranopharyngiomas, meaning high risk of pituitary insufficiency.
I think one thing I would add to that too is that with pituitary adenomas, it's very rare that they would also have any symptoms of AVP deficiency or diabetes insipidus as one of their signs before surgery. Certainly there can be other hormone deficits before surgery, like adrenal insufficiency, hypothyroidism, but DI is very rare with pituitary adenomas. But with Rathke cleft cyst, and particularly with craniopharyngioma, DI is not uncommon. And so a lot of times we're managing that from an endocrine perspective.
Yes. So, yes, he's asking. You're asking if what happens when your pituitary is gone, right? When you have no pituitary. Right. Yes. Exactly. So actually, this happens. This is a routine thing with pituitary surgery because you often have a large tumor, and then the pituitary gland We used to be like, you know, a round thing. It's been pushed and it's been smashed and it's flattened on one side. So it's a very thin gland. You remove the tumor, the gland collapses, but it's a small tissue with a very expanded large cella because the tumor expanded that area. So you have a large empty space that fills up with brain fluid, with cerebrospinal fluid. Yes, and brain fluid, exactly. The important thing here is that that fluid is separated from the nasal cavity. There is no connection, because if there is a connection, you can get infections. You can get leaking of fluid through the nose, and the same way the fluid comes out, the bacteria can go in, and you can get meningitis from that. And that's the importance. Yes.
Just have a observation. So I don't live in California, so I had to fly here, and I lost my vision on the right side, and I couldn't read. But then I went with an airplane, of course, and suddenly I can read everything, even what I was not able before to read, even like really tiny print. So I don't know if the low pressure in there just you know, was weird.
That is weird. It really is. But it would be interesting for a neuro-ophthalmology team to see, to evaluate you for sure. Yes.
The air.
Up in the air. Yes.
Hi. I had surgery in 2015, and then I had for Raschke cyst. I had another surgery this year in March for the Raschke cyst came back. And they did some new like technologies from eight years ago till now. So I was wondering if there's like any new innovations coming up to pipeline.
In particular for Raschke cleft cyst, they do have a higher recurrence rate than pituitary adenomas, generally speaking. It can be 10 or even 20% that they can. We have developed some, there are some tricks we use to trying to reduce the recurrence rates. And there are a number of them. We went from placing a little piece of catheter inside, like a little plastic, so it doesn't close up. The problem with this is, imagine this is a cyst. Imagine you have like an egg, and you open the bottom of the egg, you empty the yolk, and then, but the egg itself is pituitary glands. You cannot remove the cyst itself because it's your normal pituitary. You just empty the cyst. What you want is not for the yolk to reaccumulate inside the cyst. So what we've done a number of things, put a little piece of catheter. There is something called a stent. It's like another plastic material you can place inside so it doesn't close off. The one I like the best, we don't do it up front because we believe in wide drainage. Most of them don't recur, but if it recurs, then what we do is we use a little flap of tissue, your own tissue from the septal flap, the same we use to reconstruct the skull base, but much thinner, and that piece of tissue goes inside. And that way it doesn't close off. So that's the trick we use for Raschke cleft cysts that are recurrent. That's a different. If you have a spinal fluid leak, then you have to put a flap to close that spinal fluid leak, and therefore the risk of the cyst reaccumulation is higher because you are closing it off again. So that's a bit more problematic. Yes. Yes.
Dr. Fernandez, on the subject of the flap. So say you've had that done, and that's to prevent the spinal fluid from breaching, correct? And so therefore you have perhaps less issues of infection and so on. What are things that could happen if you do have the flap in the future? Could it not work? What do you see the issues of it failing are, or what happens naturally over time that might compromise that flap?
You can be reassured that it doesn't fail. Once it heals, it really heals well. The only situation where we've seen failure in a delayed fashion is patients that need to undergo radiotherapy. And that is not for pituitary tumors, or that would be rare, but there are some type of tumors we do. The most frequent example is something called chordoma. It's a tumor that comes from the bone where the cella, where the pituitary sits, just below the pituitary gland. This is a type of cancer of the bone. So then you have to remove all that bone and the tumor that is involved in it, and then you put the flap. And these patients often require radiation afterwards, and this is heavy radiation. Maybe, I don't know if Ellie's still around. I know, yeah. So this, yes, maybe you really want to comment, but this is one of the main issues that radiation could injure those vascularized tissues and close necrosis of the flap, and then you get leaking and meningitis and all that. But it's all in that situation. Yes, and it would not be because of CyberKnife. I don't think CyberKnife has ever caused that. Or radiosurgery in general is IMRT or the 6-7 weeks of radiation treatment. You gonna make any comment, Noel?
You mean like for the chordoma? Comment?
Radiation in general causing injury to tissues like the septal flap or injury to tissues in general, I'm not sure.
Yeah, I think it's fairly uncommon, but it does depend on the kind of flap. And like Dr. JFM said, it depends on the dose that we have to use. So some tumors like chordomas, for instance, in order to control them, you have to give a pretty high radiation dose. And then I guess this just ties into my talk and some of the nuances. We'll sometimes use the CyberKnife machine to give that higher radiation dose and try to spare the normal structures. So it's actually not as a ablative treatment. It'll be a fractionated, but on the CyberKnife. But yeah, it just kind of depends on the clinical context on the flap and how high a dose we have to give.
Radiation of the brain and let's say pituitary or other tumors, pituitary tumors, is it possible that you actually through the radiation or stress develop some other tumors in your brain, or is it unlikely?
I'm gonna pass that to Ellie. To Elle, please.
Yeah, great question. This depends on the technique. So it's a really good point you bring up. So with benign tumors, one of the reasons we try to treat with an ablative modality like Gamma knife or CyberKnife and using SRS is to try to keep that gradient really tight and spare the normal brain. So with radiation, there's a concern. One of the late effects is like causing a cancer. So especially somebody who has a benign condition or even commented on non-tumor conditions that we treat. And so typically we're trying to treat with SRS or ablative treatment to a very focal target because of that concern that you can cause a cancer later in life. Now, some of the patients we're treating are older. And so the typical numbers that people will quote is every 10 to 20 years, a 1 to 2% chance of developing a cancer. With the more traditional radiation forms, when you have to treat like a broader field. So some of these patients might be in their 80s. This is less of a concern. For younger patients, it's more of a concern. Their tissues are also more susceptible, so it could be higher risk. So oftentimes, like with very young patients, if we're using radiation, it's a broader field radiation. It's because the benefit outweighs the risk. It's kind of, I guess using the phrase again, it's the last resort. Now with CyberKnife and Gamma knife and these ablative, very precise forms of treatment where the dose to the rest of the brain and other structures is very low, we say that we don't effectively see a secondary cancer in a lot of these large studies with long follow-up that are done. So I tell patients, especially like the younger patients, I can't tell you it's zero because it might be that it's something that develops, decades later, and we don't see in these, retrospective and institutional studies, but it's very, very rare. So anyways, that's kind of how I kind of talk to patients. I'm not going to say it's zero, but oftentimes it's much tinier than the chance of, complications from, let's say, a surgery or something. And effectively, we don't really see it in a lot of these studies for the ablative targeted radiation treatments.
We do have a question.
Yeah, so after Cushing's disease surgery and after the surgery, if their cortisol has dropped and we start them on hydrocortisone, we do over weeks to months try to get them on a more physiologic dose of hydrocortisone. So typically we start with a higher dose because your body has just been so used to that high cortisol levels over time. And then every few weeks, we might drop the dose down very slowly. And then eventually we may see your normal pituitary kind of wake back up again and be able to make cortisol at a normal level. And then we'll see whether or not you need to remain on hydrocortisone. So now that they're off steroids, we do want to see what are the if they may have recurrence again. So that would involve doing late night salivary cortisol tests, 24-hour urine-free cortisol tests to try to detect for that recurrence. And especially if the patient is telling you that they're having symptoms that remind them of their Cushing's disease when they were first diagnosed, I take that very seriously. And even if the labs may not yet show a change, I would want them to have frequent testing because I think there's a higher chance that they could recur sooner rather than later. And sometimes these symptoms are very subtle and it can be sometimes disheartening because a lot of times their labs come back normal. But I try to emphasize just continue to have close follow-up. It's, if it's just the cost of whatever that lab test might be, and maybe that's just completely covered. And so there's no harm in continuing to monitor for that.
Yeah, exactly. I agree. The number one thing is to diagnose the recurrence and confirm that it's a recurrence. And then the next step is figure out what to do about that recurrence, whether it's surgery, whether it's medication, whether it's radiation. Will depend on MRI findings and the chance of success of each individual therapy.
I have a question. Is there any, you have a history of heart disease, it increased like that. Is there any history of the pituitary tumors, and when they start actually operating? There's a history, somebody's keeping up with this.
Are you asking if there is an increased incidence of pituitary tumors lately, the last decades or something? Not to my understanding or to my knowledge. I don't know, Julie, you have different perspective. I don't think so. I don't think they have been linked to any external factors, any dietary factors, any environmental factors that I know of. But I mean, we remain open to the findings, but we haven't seen any that we know of.
Yeah, most pituitary tumors are sporadic. They're not from an inheritable genetic mutation. Certainly for young patients where they've developed a pituitary tumor, if they already have a family history, then we have to monitor that and their family members very closely. And there's no, universal pituitary adenoma screening protocol, as there might be for like colon cancer, for instance. But what I mentioned, I think my very first talk, is that a lot of times pituitary masses and lesions are just picked up by accident because people are getting brain scans very frequently for other reasons. And so maybe it's not that necessarily the overall rate of pituitary tumors has changed, but we're just getting more scans and imagings done.
Is there any sense that there's an impact on life expectancy for pituitary patients?
So I think most patients, even with hypopituitarism, can expect to have a very as close to normal life as we can offer with pituitary hormone replacement and just continued close follow up and monitoring with your team. I mean, that is the one good part about pituitary endocrinology, is that we do have hormones for most of the, or sorry, replacement for most of these hormones. There are some caveats. Obviously, there can be, especially with the functional pituitary tumors and how that might have changed blood sugar or blood pressure changes on their heart function over time. So that can maybe contribute to someone's overall life expectancy. But just in terms of hypopituitarism and being on hormone replacement, I always say that I expect you to lead a very normal or as close to normal life as possible.
I was just curious, in the medical practice, is there any push to have kind of more people, more doctors, maybe every 5 years or whatever, do a full hormone panel on their patients when they do their blood work for their cholesterol and whatnot, just to cast a larger net to identify people that might not yet know that they have something going on with their body?
I think that's probably very controversial. I think you have to also see what would be the cost and benefit of doing kind of general hormone screening like that. I think, one question, we heard about all the different hormone deficiencies that can occur, but sometimes not all hormone replacement is required as well. I don't push necessarily that someone is on growth hormone replacement if actually being on injections every day actually decreases their quality of life, and they feel very well without it. And similarly, sometimes with mildly low testosterone, and someone feels great just how they are. So, some of these hormones are not necessarily required, as long as they feel well and they feel like their quality of life is actually quite good. Yeah, for screening. And so I think that would be the potentially the drawback, is that you're maybe diagnosing or finding these hormone abnormalities. I think, if you do find it, then it of course is a conversation, but I don't see, at least in the near future, of that becoming a routine universal approach.
You have to calculate what is called intention to treat or intention to diagnose, which means you probably have to do many thousands of blood tests in patients to detect, let's say, one patient with acromegaly that don't know about. So it probably will not be implemented. I don't think so.
Also could be dealing with insurance issues, health systems.
After the tumor is removed, that gap is filled with the brain liquid. And so you mentioned that it might get infected. How would you tell that it's infected?
No, if the fluid is isolated, it will not get infected. Isolated means isolated from the nasal cavity. It becomes in the brain, we have what we call cisterns. Cisterns are spaces filled up with fluid. And these are natural spaces, and the fluid flows from one system to the other. And this area becomes another system, another space where fluid accumulates. Yes, yes.
I follow the pituitary world. I don't know, whatever Dr. Blevins does, he has that thing. And they had a study, this is kind of related to, what might promote a pituitary tumor. And there was one study not too long ago about how alcoholism in your family and stress and anxiety were a commonality to a lot of people with pituitary tumors. For me, I have it in my family, and I feel like I've been stressed ever since I was probably in my mother's belly, because, it's chaotic and dramatic and awful. But and then my tumors were producing huge amounts of cortisol. One was functioning and then another one was non-functional, but just, cortisol running high all the time. I just wonder if that would force a pituitary into dysfunction in some way.
So I can maybe start to answer that second part of that question about just the impact of chronic stress on the body and how that might impact pituitary function. I think there was a question kind of similar to that about trauma in life. And so having these kind of mildly high or just chronically high stress levels day to day, while that might not necessarily be Cushing's disease from like a tumor that's overproducing ACTH or cortisol, that can have impacts on people's quality of life. And there's an entity called non-neoplastic hypercortisolism, which basically means high cortisol from not a tumor source. It was in the past, we've also referred to that as pseudo Cushing's. And you can have these high cortisol levels on lab testing, kind of similar, almost similar to Cushing syndrome, but not actually have the tumor. And so when we see that, we try to identify very carefully what might be causing that and trying to treat kind of that secondary cause and removing someone or treating, maybe whether it's a mood disorder or alcohol use or the source of the stress. And I will say that, cortisol is made from the adrenal gland. So actually that's going to feed back and not necessarily cause a pituitary tumor. So those are distinct. So the ACTH producing hormone, pituitary hormones are distinct from cortisol producing tumors.
Now I'm just gonna stress. It's complicated, right? It's not always easy. It's really fast. Pros and cons of complex motivations. And so I think it really is, you're all faced with those stressors. On what you're doing, choosing to do to massage that to a place of you that's not going to be too hard. The direct relationship between shared physiological and not psychological to being a human being. So if you know you're going into a major stressor, something's coming, utilize mindfulness exercise, writing, drawing, big believer in music. So really incorporate some of those tools.
It's been a great session. Thank you, everybody, for joining us.